Chapter 13, Government Incentive Programs. To me, this chapter was a bit heavy. Maybe it was just me, but there's a lot of information in there, so I want you to go into this chapter with an open mind and take as many notes as you need. The government incentive programs are nothing new. They've been around for a while. Back in the 90s, they were very different. I was about to say slightly different, but they're very different today compared to what they were 20, 25, 30 years ago. Introduction starts out talking about the electronic health record, and we've already reviewed that. There's other programs offered by the government that aim to incentivize healthcare providers by demonstrating the delivery of quality healthcare. So I've said it, especially in the beginning of this course, the changes in the health insurance regulations and just healthcare regulations altogether, the goal is always quality outcomes. But we have to have a way to measure that. We have to have a way to enforce that. And that's what this course is all about. Well, some of it is about. And financing it and paying for things. They used to, fees would be paid based off the number of items or actions that were completed, whether the patient had a good outcome or not. Now the payment is solely based on value. And I'll get to that. I'm going to review this chapter with you guys. Several programs provide incentives to healthcare providers for quality outcome. The first one is pay for performance. The second is hospital value-based purchasing. And the third, there are medical homes. And we're going to get into that in the chapter. On page 224 of this book, it starts out with pay for performance. In the past, Medicare and other payers have reimbursed healthcare providers on a fee basis. The providers were reimbursed for all the services they provided to the patient. The higher payment did not necessarily mean the patient received better care, so they made changes, and I just spoke to that. And this is a great little paragraph in this chapter. The goal is to allow outcome, what treatment for a patient to influence the payment. So again, they stopped paying based off of the number of services. They started paying based on the outcome. And when I'm referring to Medicare first and foremost, but there are private sectors that do this also. So the typical pay for performance program will provide a bonus to healthcare providers for meeting or exceeding an agreed upon quality measure. Important to know that it's agreed upon and that's how they receive that bonus. There are 4 quality measures: process, outcome, patient experience, and structure. And I'm not going to read that paragraph to you, but the paragraph does a great job describing them and explaining what they are. Stakeholders using pay for performance also. Again, public sectors, initiatives that include Medicaid and Medicare that have been the leaders in the pay performance environment. So Medicaid and Medicare, they developed the pay for performance idea, but private sectors and stakeholders have followed suit. Medicaid, unfortunately, though, has historically lower reimbursement than other plans. So that's why if you've ever been on Medicaid or Medicare yourself, or if you know somebody and they have a hard time finding a doctor or a provider, that's why. Doctors and providers oftentimes do not accept Medicaid or Medicare because they do reimburse such a low amount. I think when I went back for my master's degree in nursing education, at that time, I considered becoming a nurse practitioner, which would make me a provider, but Medicaid and Medicare was only reimbursing 20 cents on $1. That would have been like 2010. So I don't know what their reimbursement rate is right now, but had I chosen to go into the nurse practitioner realm, I likely myself would not have accepted Medicaid and Medicare patients, because who wants to be reimbursed 20 cents on $1? But there's improvements coming. And like I said, that was 10 years ago. I don't know what the reimbursement rate is right now. Nothing, you do not need to know that for a quiz or a test. That's just me providing some context to what I'm referring to. Okay, page 225, bottom right, private sector initiative. Health plans have also initiated pay for performance programs that financially reward physicians for quality care. Again, it's all about quality, appropriate care, accountability, and transparency when reporting publicly their results. So lots of things have happened in the past 10 years in healthcare, and one of those items is the transparency and reporting their results. You can actually search your doctors, your providers, who has the best results, who has a history of surgical infections, who has bedside manner. There's all sorts of sites and portals, web portals, if you will, to find that. And you guys may hear my dogs barking. They are being a little barky today for whatever reason. All right, page 226. There's return on investment calculators. The next paragraph is quality indicators. Quality indicators and process measures have been developed for the healthcare industry and are continually being refined. These measures, such as web-based portals, increase consumer awareness, and it goes into different sites there that you could check out. The next section is hospital VBP program. That is value-based purchasing. That's what that stands for. It is a CMS initiative that rewards acute care hospitals and with incentive payments based on the quality of care. Again, more incentives based off the quality of care. Not how many times you saw the patient, not how many tests you ordered for the patient, but the quality of the care and the outcome. To achieve this goal, CMS is committed to providing care for the Medicare patient that is safe, effective, and timely, etc. Overall, the goal of value-based purchasing is to avoid the payment for care based on the quantity of care or services. They want to pay based on the quality outcome, quality measures. All right, 227, that page goes into the history of everything that I'm referring to and the goals of the program. So the U.S. healthcare system needed a new system that could be developed that would improve the care delivered to the patient, that would in turn improve value of care delivered to the beneficiary, again, the patient. CMS defined the following goals. They refer to improve clinical quality, reduce adverse events, encourage more patient-centered care, avoid unnecessary costs, stimulate investments, whether it's IT or care management tools, and make performance results transparent and understandable to the public and to patients. Okay, page 228. Quality domains. There are 4 applicable domains for hospitals to be measured on: clinical process of care, patient experience of care, outcome, and efficiency. And I'm not going to read those to you. They're they're detailed on pages 228, 229. Participating hospitals, scoring of hospital performance, that's mentioned on 230. Value-based purchasing program periods. There are 2 periods are used in capturing data on how well a hospital is performing. Those data points are done in the performance period and a baseline period. And there are several charts and tables here in this chapter that are really good information. Page 232, I'm just keeping on going. I need to go see what my dogs are barking at. Hospital consumer assessment of healthcare providers and systems. So the HCA-HPS is a standardized survey and data collection tool that's been used since 2006. I can remember, side note here, I can remember as a nurse, I think I was in the operating room at the time, when this survey became such a big hot topic. Suddenly we went from a hospital-minded customer service to almost a hospitality customer service mindset, if you will. I can remember some peers of mine who were resistant to the change, would say, well, this is not a hotel, this is a hospital, and you get what you get. And, well, no, that changed when this survey came out, because then patients were starting to be surveyed on how they perceived their health care. And then the hospital got reimbursed based off these survey results. So let me keep going in this chapter. 3 goals define or shape the survey. First is designed to produce consistent data that could be compared. Then the public reporting Oh, I missed a section. Public reporting of the survey results are shared, and the idea of public reporting will enhance public accountability of the hospital. And that is exactly what happened in my experience. Again, we shifted our mindset to really being hospitable and treating our patients and their family members and guests like they were at a hotel, like we were a world-class institution who smiled and greeted people and helped people find their way, etc. I mean, we attended all kinds of trainings and workshops because this was a new idea to us. You know, some healthcare providers, nurses, even the environmental services folks everywhere, from the bottom to the top, if you will, we were so focused on taking care of people, we weren't always necessarily the nicest, kindest. We got the job done, but now we're looking more at our patients as a whole. You do have to be nice, you do have to be kind, you have to share information, yet you still have to have that knowledge of being a healthcare provider and etc. Anyway, I'm getting off on that sidebar, but it really did change things about 15 years ago, how we provided our care. Okay. So survey content. The survey is extremely important. It is administered as a random sample that includes adult inpatients who were discharged from an inpatient hospital between 48 hours and 6 weeks and were admitted to medical, surgical, maternity, floor, or wing. So again, that surgical key component, that's why as an operating room nurse, it became such a big deal to us. Our surgical patients were going to be surveyed. Maternity patients are surveyed. I don't know if you, again, another sidebar, sorry you guys. I don't know if you remember a few years ago, maybe 10 years ago, maternity hospitals were advertising steak dinners. If you come and deliver your baby here, you'll get a steak dinner, and different influences, if you will, again, to provide that excellent customer service and provide quality outcomes. They were really, what's the word I'm looking for? Advertising and trying to seek out customers. And that was new. Hospitals didn't used to do that. But we wanted customers and we wanted good outcomes and we wanted excellent feedback. Okay, let me continue. Page 233 on the right-hand side. What does the survey measure? There's 8 areas and items, and I'm not going to go through. You guys can read this. It's amazing what it covers, and if you've ever received one of these surveys, or if you know of anybody, it's pretty interesting, the results. Okay, page 234. We're almost done. Patient-centered medical homes. Now, this is very interesting. This started as a demonstration project to help in the redesign of healthcare delivery model. The goal was to provide targeted, accessible, continuous, and coordinated family-centered care to high-need populations. All right, so these type of people, a high-need person who could essentially be considered for a medical home, is an individual with multiple chronic illnesses that require ongoing monitoring, advising, or treatment of their condition. And then here we're going to talk about the comprehensive care. And the PCMH is the medical home that I'm referring to. It is responsible for supplying a large portion of the patient's physical and mental health care needs. This includes the physicians, the nurses, the physician assistants, pharmacists, nutritionists, whether it's wellness, acute care, treating the chronic disease, etc. It compiles it all. The PCMH will provide primary care to their patients, focus on the relationship of the patient, and will treat the whole person. So nothing's excluded. They treat it all. Coordinated care will need to facilitate care across more significant portion of the patient's care plan. And the PCMH is responsible for delivering services that are readily available. Again, quality and safety. PCMH needs to demonstrate high level of commitment to quality care and continuous improvement. And that's key with healthcare finance too. There's always changes. There's always continuous improvement. So what you guys learn in this course may change in a year or 3 years or 5 years, but at least you're gonna have this base knowledge. Okay, page 235, Independence at Home Demonstration Projects. So IAH was created by the Affordable Care Act. Delivery and payment incentive model that is using home-based primary care teams. These teams focus on improving health outcomes and ultimately reducing healthcare costs. Requirements for this participation: to participate in an IAH, the practice must show that they are familiar with and have adequate experience in delivering primary care in a patient's home setting. So, sidebar again, doctors making house calls. That this is what comes to my mind. That group, there is actually a IAH group called Doctors Making House Calls, and they literally visit people of all types who are not necessarily homebound, but they serve in a full capacity. They draw labs, they do mental evaluations, primary care type visits, wellness visits, sick visits, and they go to people's home. Okay, to be eligible to be considered for an IAH, the person must have 2 or more chronic conditions and have health coverage from Medicare FFS. All right, financial incentives is our next chapter. The practice must succeed in offering a high level of quality care to be considered for financial incentives, of course. Okay, and I think we're finally arrived at our last section here. We have, Comprehensive Primary Care Plus. According to CMS, the CPC Plus is defined as a national advanced primary care medical home model. It aims to strengthen primary care through multi-payer payment reform and care delivery transformation. 5-year program, it has 2 tracks. The overall goal of the program is to tie together improving patient care and outcomes and decreasing the overall cost of care provided. Makes sense, right? Get better outcomes while spending less money. Performance-based incentive payments. The amount of payment that is earned by the practice is calculated by the number of patients who are assigned to a practice. The track of the practice in the CPC Plus program and the practice's overall performance to the measures of the CPC Plus program. So again, more incentives, and that's how they are measured. That's how they're awarded those incentives. Page 237 on the right-hand side, the Attribution Methodologies. You can read that paragraph. Unit of assignment is where CMS assigns a patient to an entire practice or an individual practitioner for different reasons. Page 238, look back period. CMS, they can pull Medicare claims during the 24-month look back to identify eligible primary care visits for attribution. Eligible primary care visits is the next section. Risk scores, tiers, related payments. Again, I just thought this was a heavy chapter. And conclusion, the emphasis on quality of patient care is demonstrated by the introduction of the pay-for-performance and value-based purchasing models. Okay, that's a lot. You guys have this video to listen to. You have the PowerPoint. You're going to take a quiz this week. And there is a discussion, but I don't think there is a case study. So let me know if you need me for anything. Hope you guys are having a great semester.